My name is Rajita Menon, and I am, as mentioned, a scientist leading the data science team at Vedanta Biosciences. And today I will be sharing results from the phase 2 consortium study in patients with C. difficile and showing you some of the effects of VE303, the defined bacterial consortium that we have developed for C. diff infection. And I think the organizers did a great job teeing up this talk right after Dr. Conrad, because that is the phase 3 trial for this product that is currently ongoing. So before I start my talk, these are my disclosures. VE303 is an investigational product, and this work was funded in part with federal funds from BARDA. So in recent years, we've seen welcome developments in the field of microbiome therapies, right? So we've seen the approval of these two donor-derived treatments designated as fecal microbiota products by the FDA. And then we have defined bacterial consortia like VE303, also in advanced clinical trials. And these are classed as live biotherapeutic products, or LBPs, by the FDA. And both LBPs and fecal microbiota products aim to modulate the microbial ecology of the patients and to reverse disease-related changes. But there are some fundamental differences between these treatment classes in terms of standardization, supply, and safety. So fecal microbiota products have inherent variability in composition and quality, and they are difficult to produce at scale. There is, of course, a risk of pathogen contamination, which can be mitigated, but it requires extensive and costly donor screening. In contrast, for LBPs, or defined consortia, we manufacture these from cell banks, with each capsule containing the same composition of bacteria in the same amounts. And they can be readily manufactured at scale. They essentially eliminate the risk of pathogen transfer. And my talk this afternoon will highlight VE303, as I mentioned, which was designed for the treatment of C. difficile infection. And this slide was briefly flashed by Dr. Conrad. It shows the 8 strains that comprise VE303 in all of their glory. VE303 is a defined consortium of 8 firmicutes, and these strains have no known virulence factors or clinically relevant antibiotic resistance genes. And we know that VE303 suppresses the growth of C. difficile in vitro, and that it can achieve in vivo efficacy that's comparable to FMT in a mouse model of C. diff infection. And additionally, we know that the strains can produce a number of beneficial metabolites that are known to suppress C. diff-induced colitis and otherwise ameliorate inflammation. So short-chain fatty acids, as well as they encode genes required to convert primary to secondary bile acids. So this is sort of established from preclinical and in silico work that we've done. And for the drug product itself, the strains are grown from clonal cell banks under good manufacturing practice conditions. And this enables a consistent and a stable drug product. And we have completed 2 clinical trials with VE303. So in phase 1, in a dose-ranging study in healthy volunteers, we showed that the consortium was well tolerated and it had durable and dose-dependent colonization out to 1 year post-dosing. And in phase 2, VE303 reduced the rate of recurrence in patients with C. diff compared with placebo. And as mentioned, it's currently being tested in phase 3 in a larger cohort of patients. But today, we're going to focus on the phase 2 trial results. And so just to introduce what the study design looked like in the phase 2 consortium study, we had 79 participants that were at high risk for recurrence and were given VE303 or placebo following standard of care antibiotics. VE303 was given at 2 doses. Both were given over 14 days. The high dose repeated the selected regimen that was found to be sort of the most consistent from our phase 1 dose ranging study, whereas the low dose amounted to 1/5 the total dose of the high dose. C. diff recurrence was assessed at week 8, and we had a safety follow-up of 24 weeks. The goal was to determine the effect of VE303 on recurrence, identify the recommended dose for a phase 3 study, and characterize the colonization of VE303 and changes in the participant microbiome. So in the study, we observed that 86% of participants with C. difficile who received the higher VE303 dose did not recur. In this plot showing the probability of recurrence on the y-axis, the red high-dose group had a 31.7% absolute risk reduction in the rate of a recurrence when compared with placebo in blue. And this represents a greater than 80% reduction in the odds of a recurrence. Overall, we found that VE303 strain colonization was more pronounced in the high dose group. So the number of strains detected in the participants, shown here on the y-axis, was significantly greater in both the dosed groups compared with the placebo and in the high dose compared with the low dose group. And then when we combined the two active treatment arms, we found that participants with high VE303 colonization, shown here in teal, had a significantly lower recurrence probability, regardless of which dose they received. And here, high colonization was defined as 5 or more strains getting into the participant. So we saw this link between overall colonization and response in study participants. But the colonization per group was variable across the strains. So here I'm showing you on the left the strain prevalence on the y-axis. So it's the percentage of participants with the strain detected by day 14 across all 8 strains. And this was generally higher in the high dose versus the low dose. And the prevalence ranged from 10 to 90% across these different strains. However, we do think that there was room to get improvement in these colonization rates, and we would like to figure out how to boost these. So we did some analysis to identify predictors of colonization. We built a machine learning model on our screening samples, and we have a wealth of data available for this. We have bacterial, microbial abundances, we have metabolite information and immune cytokine profiles, as well as patient-level data like demographics, medical history, et cetera. And on the right-hand side, I'm showing you a snapshot of the predictors that came out of this model. And the red boxes here are features that predicted lower colonization. The teal boxes were features that predicted higher colonization. And we found essentially that VE303 strains tended to colonize poorly in individuals with higher inflammation. And this was indicated by higher levels of immune cytokines and primary bile acids. In contrast, colonization was increased in participants who were given vancomycin versus fidaxomicin as their standard of care antibiotic for the qualifying C. diff episode. And so this is just a small subset of all of the analysis that we did. If you would like to check out all of our colonization and multi-omic data, this was published earlier this year in Nature Medicine. So please feel free to check that out. So we were interested in this observation of antibiotic type and colonization. We wanted to dig deeper into this. And so just a bit of background, we did note that the majority of participants in the study received vancomycin 4 times a day as their standard of care antibiotic. Among the dosed group who received 303, we had 41 vancomycin recipients and 12 fidaxomicin and just a handful, 1 or 2 of other antibiotic types. So we focused on the 2 vancomycin and fidaxomicin groups for this analysis. And we found that when we compare these participants, vancomycin treatment, that's in teal over here, achieved a significantly greater drop in bacterial diversity from screening to day 1. So start of antibiotics to the end of antibiotics and before we come in with VE303. So in this plot over here, if the box is above the red line, that indicates a improved clearance, whereas if it's at the red line, it indicates no change. And this is interesting because it suggests that improved clearance can open up a niche for the 303 strains to colonize. And on the right-hand side here, you can see that the colonization of each strain over the first month was higher in vancomycin versus fidaxomicin treated individuals. So we also looked at the vancomycin levels in the stool over time in the bottom plot over here, vancomycins on the Y. And we found that the vancomycin was largely cleared from the stool by day 14 in both the low dose and the high dose groups. And I'm not showing placebo, but this pattern was consistent for placebo as well. But interestingly, during these 14 days, we are also actively dosing with VE303. And we found that the strain colonization during these 14 days was strongly negatively correlated with the actual vancomycin levels. So we end up with this sort of subtlety where vancomycin facilitates greater colonization by creating space in the gut. but it can also lower colonization by inhibiting VE303 strains, which are susceptible to vancomycin. So this really shows the importance of dosing continuously all the way through the 14-day period so that the strains can take advantage of the ecological niche while overcoming the suppression due to vancomycin. Okay, so thus far, I have shown you that 303 colonization is linked to response outcomes, and we've looked at some of the factors predicting colonization. And for the rest of the talk, I'm going to shift gears to the recovery of the participant microbiome and the metabolites in the stool. And looking at the microbiome recovery essentially can signal a reversal of microbial dysbiosis, which is very relevant to C. difficile, of course. And looking at changes in the stool metabolites, including the short chain fatty acids and bile acids, these are metabolites that are thought to and are understood to affect gut function, barrier repair, and inflammation. So these analyses really help us understand what are the potential mechanisms by which VE303 might be acting. So I'll start with a high-level measure of microbiome recovery, which is the species diversity. So on the top plot, the y-axis is showing the species diversity. And we saw that diversity recovered over time in all of the 3 treatment groups. So we see this dip, then this recovery pattern. But the recovery was the most rapid in the high-dose group. And then by day 14, we found that the high-dose participants had a significantly higher diversity, both compared to their baseline samples and compared to their placebo counterparts at the same time. Increased diversity was associated with response outcomes. So as you can see on the bottom here, the blue boxes are higher than the red boxes. That's the blue is non-recurrent and the red is recurrent. And then the delta, that's the difference between the boxes, was dose dependent, and it was greatest for the high dose group. And all of this suggested that 303 mediated recovery of the endogenous microbes is contributing to the improved response in the high dose group. To infer specifically which taxa correlated with clinical outcomes, we fit this linear mixed effects model, and helps us account for repeated samplings across the treatment arms because we have longitudinal data collection in the study. And this plot, which is known as a volcano plot, it shows recurrence associations to the left and non-recurrence associations to the right. And each dot is a different species. And if it's above the red line, that indicates more significant associations. So basically, you want to be looking at the top right quadrant here, which is significant associations with non-recurrence. And here, the 2 organisms, 303, O2, and O8, an Anaerotrunchus and a flavonifractor species, these were the top predictors of non-recurrence amongst all of our 378 or so species that were included in this analysis. So looking at the metabolite concentrations, we found that several metabolites were associated with clinical outcomes by day 14. And these features that I'm showing here were picked up as important in our machine learning model. We fit a random forest for this analysis. We see that some of the primary bile acids tended to be elevated in the recurrent group as compared to the non-recurrent, whereas the secondary bile acids in here, it's lithocolic and ursodeoxycholic acid, were significantly increased in non-recurrence. And amongst the short chain fatty acids, there was butyrate, hexanoate, isovalerate that were significantly increased in non-recurrence. And these are a lot of technical kind of names, but it's interesting to observe that these 3 like smoking guns sort of that came up here are consistent with the literature. We know that UDCA is a secondary bile acid that has been linked to gut health and can have direct inhibitory effects on C. diff spore germination. Similarly, butyrate has been shown to be important for C. diff colonization resistance and can protect against C. diff-induced colitis. And then the last data slide that I'm going to show today is just a correlation analysis that we did to connect the concentrations of these metabolites to the abundance of the host bacteria, endogenous bacteria, as well as VE303 organisms. And in here, the blue boxes show positive correlations, and the red boxes show negative correlations between the indicated metabolite and bacteria pair. So metabolites on the Y, bacteria on the X. And the white shows no significance. So we found here again that the VE303 strains were strongly correlated with UDCA. And 5 of the 8 strains were correlated with short-chain fatty acids, including acetate and butyrate. And these observations are also consistent with our own in vitro studies of short-chain fatty acid production by VE303. Multiple of the strains can produce acetate, butyrate, and propionate. And that includes the strains 2 and 8 that came up earlier as associated with non-recurrence. So this brings me to the end of the talk. I shared results from the VE303 Consortium study in patients with C. difficile, where the high dose had a significantly improved clinical response compared with placebo. The high dose also showed superior colonization of VE303 strains and led to early restoration of the endogenous microbiota and mirroring the clinical response that was observed in the high dose. Increased overall colonization, that's 5 or more strains getting in, was associated with non-recurrence. And taken together, our data suggests that VE303 mediated microbiome recovery and strain colonization provide a rationale for the observed clinical response in the high dose in our study. And as I conclude this talk, I want to bring it back to our global phase 3 study of VE303 that's taking place in 23 countries across 4 continents. We believe that this is the first randomized placebo-controlled phase 3 study of a defined bacterial consortium. And I would be very happy to take any questions. Thank you very much.
Well, thank you very much. That was really interesting. Being in this for almost 16 years now, it's been very interesting to watch, us get Rebiota and VOWST to now look at these sort of non-donor inputs and what the possibility might be, because I just feel like we've barely scratched the surface of what we might be able to do with microbiome therapeutics in the future. We did have one question, which was, could this be used for treatment for those with severe C. diff? And also, and I think this is true, I don't think it's this drug, but also is eventually the plan to allow this for those with inflammatory bowel disease?
We are currently testing we have our large cohort of C. diff patients that are being tested in our phase 3 trial. And I believe that we will learn more. I don't think we were able to establish in phase 2 whether or not we have subpopulations that would be enriched, right, that we would be able to treat better with VE303. But yes, so at the moment, I'm not sure I can comment on that, but I think once we have a better understanding of the efficacy from phase 3, we'd be able to kind of comment on that more.
Yeah, sometimes it's just too early. We don't know yet.
Right.
So Dr. Rao asks, would you hypothesize that greater VE303 efficacy after vancomycin compared to vitaxomycin?
Right. So we did look at that but unfortunately, because we had a small clinical trial, right, it's 80 patients. And like I mentioned, in the dosed participants, we only had 12 fidaxomicin and 41 vancomycin. So when you shake it down then by recurrence, non-recurrence, it's really hard to tell whether there was increased efficacy. But perhaps that is the implication. And because we think that the mechanism, at least partly, is mediated by increased colonization, and we did find that colonization was associated with efficacy, and vancomycin did lead to improved colonization in this data set. So I think in that sense, we are recommending that we really use an intervention that allows the strains to colonize. And whether that's vancomycin or whether that's like dosing with fibers or other alternative kind of ideas that we are working on as a team, that's sort of a question for the future. But I would say between vanco and fidaxo in our study, I think our evidence suggests that it was the vancomycin achieved better colonization, and that is potentially related to efficacy, even though, directly when we compare the groups, we don't have the power to look to discern an effect.
Yeah, study's just not big enough to really be able to
yes.
count on that. Then Jacob asked, do you plan to stick with VENC or FIDAX to clear the ecological niches for strain engraftment, or are there any plans for a different narrower spectrum antibiotic?
Yeah, that's, I think, this excellent questions. So for our phase 3, we are using vancomycin as our standard of care recommendation. And I believe, if the field shifts with what is recommended for standard of care for patients, I don't know how that would change in the future. I will say that at Vedanta, we are broadly thinking about interventions that would allow us to engraft better with our strains, and for VE303 and for other LBPs as well. And we are certainly thinking about ways that, say, prebiotics or fiber supplementation can achieve improved colonization. And this is also relevant when it comes to thinking about immune compromised patient populations, right? So for the moment, for VE303, we are still using vancomycin. But I think as a company, we are certainly thinking about alternative ways to improve colonization.